Ongoing healthcare workers strike by Brown Ashira, Secretary General Kepu, and Christine Wanjiru, Secretary General of the Clinical Officers Dermatologists Association, Kajiado. Welcome to TV47 Prime, and thank you for making the time.
Thank you, Peter.
Yes,
it's a pleasure. Asante.
Karibuni sana.
Asante.
Brown, for
yes.
viewers who may not fully understand the dispute, what exactly triggered the strike?
Well, thank you so much, Peter, and TV47. My name is Brown. I'm the General Secretary for the Public Health Union. KEFU means Kenyan Environmental Health and Public Health Practitioners Union. Mm-hmm. We are specialists in preventive medicine. We study environmental health sciences, and therefore we do preventive issues. The main issue why all the healthcare actually is under strain, or rather is under paralysis in this country currently, is because of the whole issue about the UHC. I know there are a lot of issues going through that, because as a union, as Public Health Union, we actually have quite a number of our colleagues under the UHC program, that's the Universal Health Coverage Program, mm-hmm. who have served this country since the onset of COVID-19. They have actually done close to 6 years under contract, and you know very well that the Employment Act is actually very clear that somebody is not supposed to serve to that extent. And therefore, we have been seeing a push and pull between the two levels of government, that is the national government and the Council of Governors, where they have not actually managed to guarantee. Actually, we went on strike and actually looked for money, and there was money that was actually appropriated in the parliament for them to be confirmed under permanent and pensionable establishment, but we've had a push and pull between the two levels of government. That's why we have our colleagues on strike, and therefore we are saying that if that issue can be addressed as quickly as possible, we can be able to resolve the issue, the impasse, then we can be able to go back now to work as other healthcare workers in this country. Yes.
Okay.
Yep.
Christine?
Yes, please. Good evening, and my name is Christine. I'm a clinical dermatologist, and on this position, I'm the Kajiado Gender Branch Secretary. But again, matters Kenya Union of Clinical Officers. We very well know that we went on strike from 20th of July because we had 5 key areas that we needed addressed. One of them, of course, is what my colleague in studio has said about the Universal Health Coverage Team, and again, by extension, the Global Health people, that these people have been operations for so many years, and unfortunately the government has always turned a blind eye and a deaf ear to their demands. The fact that we understand now the UHC team, of course clinical officers are part of them, have already been absorbed. But again, there are other 4 more areas that we need addressed by the government. One of them is that we want to ensure that the team does not just go back with the permanent and pensionable letters, but let them also get gratuity. This is that 1% of the basic annual salary that they should be given for the years that they've been in service. And on top of that, we know in 6 months ago, that is on 28th of January 2026, we were on strike. We signed a return to work agreement, and the agreement majorly encompassed on having the 47 county governments sign the CBA, the collective bargaining agreement. Unfortunately, none of that happened. 5 months down the line, we've been having back and forth consultations, and they've always been telling us we are coming to the table. Now up to 20th of July, when we said enough is enough, now we're on the streets and we are demanding 47 county governments sign the CBA, and on top of that, let the scheme of service for clinical officers be addressed in total. Mm-hmm. We don't want partiality. We don't want today we are being told promises, we go back to work, and then later on it becomes music, it becomes a back and forth issue. Yes, thank you.
You've mentioned a number of issues.
I wanted to add something.
Yes, yes.
Because I think, thank you, Dr. You've actually tried to explore almost everything.
Yeah, please.
But on our end, also apart from the CBA for the clinical officers, as public health officers also want to see a centralized negotiation on recognition agreement. Remember, Peter, when the union is registered in this country, it requires that they be recognized by different levels of government. And we want to see the Council of Governors or the types of governments having a centralized way of negotiation, because a recognition agreement is supposed to be a unique document. It's not actually unique to Wajir or Nairobi. It's supposed to be uniform to each and every county. Therefore, that's a part of the issues that we're trying to raise, that we need to make sure that we have a uniform way of negotiating as unions, so that we can be able to harmonize what we actually be able to say. But before we go much further, allow me to go a bit straight and say thank you to the CS. A big thank you to the CS Duale, and a big thank you to His Excellency the President, because they actually brokered a deal and actually ensured that they changed the terms of the UHC colleagues at the payroll to the permanent imperishable terms. Actually, what we actually are waiting for is the real letter, the confirmation into permanent and pensionable establishment. But I want to give pongezi to His Excellency the President of this country, and also our CS, Honorable Duale, for actually unlocking that imbalance. Because remember, we had a problem. We have actually a problem, a huge problem with our governors in this country. The governors have wanted to use this as a political tool to might a lot of corruption. But now, when the president came in, when the CS came in, and they actually confirmed our colleagues into permanent and pensionable terms, now what we actually are waiting for is the real letters now to be issued. That's why we are still on strike. We want to ensure that we see the real letters now being issued to our colleagues so that we can now be able to use that. You know, a PNP letter is now a legal document you can be able to adduce anywhere to.
So why is this issue so critical? This issue of permanent and pensionable?
It's very critical because, remember, that's the one that assures you your job security. Remember, if you are actually on PNP, the only thing that can be able to give you assurance and security as a healthcare provider, we're talking about healthcare providers here, Peter, and these are actually very critical and essential people in the healthcare system, or rather in the healthcare service delivery. And lacking a PNP letter or other establishment actually exposes them to a lot of insecurity in terms of job-wise. And therefore, having that PNP establishment actually assures them, even it actually boosts their morale, and also number two, assures them of their job security. That's number one. And number two, also there are things that are actually benefits that we actually get as permanent and pensionable employees in this country. For example, the allowances a contracted officer cannot be able to get when a PNP worker actually gets. And you know, the Employment Act actually is very clear. It's supposed to, it talks about equal pay for equal value for work done. Therefore, we have to be able to harmonize all our pays and also our way of doing things. Now,
so how many health workers are affected by contractual terms and delayed appointment letters?
Now, when you talk about the contractual terms, we are talking about all healthcare workers, from the lab technicians, from the public health people, from the clinical officers. It's basically cutting across. Because remember, how did we come up to this universal health coverage? It's when COVID came knocking on our doors. There was a crisis in the healthcare department. So the government really advertised for positions, and everybody out there applied. They got absorbed into it. Come 2 years, 3 years down the line, we were able to control the COVID menace. What happened? The team was left back between the national government and the county governments. The county government says, no, we do not have enough money to sustain these people, back to the national government. So that back and forth is what has come up to date, up to 2026. And now 5 years down the line, we cannot be able to address these issues. It's such you know, it really pains my heart seeing it's today we're on strike, tomorrow we resolve it, again we go back on strike over the same issue. And also to add, also the issues of clinical officers, the other thing that we're also asking for, you're asking about, well, what we call a health risk allowance. We very well know that our healthcare workers and basically the clinical officers, they're the first point of care. The primary levels of healthcare providers, we are the people that are there on the ground. So when a person comes and you contract these communicable diseases, we just need some very few coins to be able to shield us so that you're able to take a nice comprehensive insurance to take care of your health. But now, the government has been there promising. It was part of what they promised during the return to work formula signing, but this has not been effected up to date. And
but the government says they have allocated resources.
Now, it's one thing saying they've allocated the resources, and it's another thing for each and every clinical officer out there seeing it on their payslip. You see, these are two different languages, and they can allocate resources. But again, what are we crying for? We are crying for seeing that being implemented and also paid in arrears. And lastly, there was also that issue of also ensuring that the global health team are also incorporated into this. And last but not least, about the clinical officers, the other return to work formula also talked about implementation of the scheme of service. Today they'll sign the CBA. We are seeing every day, we are seeing it on the news that this county has signed, this county has signed. And so far, just by close of business today, we only had 22 counties having signed the collective bargaining authority. So you can imagine the other 25, where are they? Now they've signed. Are they implementing it? It's one thing signing it, and it's another one having it. Exactly. Yes. And now this impasse will continue. And just to make a very humble appeal, let these things be handled as soon as possible. Let's continue serving our people, because believe you me, the economy is not doing so well. And then when you add up on healthcare issues, we talk about people cannot be able to access the affordable healthcare services that we're talking about. It's such a pity.
Brown, so who bears the responsibility for the crisis? Ministry of Health, the Council of Governors, county governments, or is it Parliament?
Both levels of government have equal responsibility in this sense. Health is a devolved function. You know, the 2010 Constitution provided a two-tier system of governance, where the national government was to do the policy, the regulation, and the standards, and then the counties were supposed to be able now to do the real work. Implement issues to do with the HRH and other issues were actually to be done by the counties. But in this case, we are seeing the Council of Governors behaving funny, because we cannot have a country that we are talking about the national government allocating resources. And you know, in this case, I'll be very fair to the national government. The national government did their bit. Honorable Duale did his bit. The president did his bit. The allocation and the appropriation was done through Parliament. Actually, it was actually passed through the Senate Health Committee. Honorable, the chair of the Senate is our good friend Mandago, and others, Dr. Nyekal, they're actually very good friends. They did their bit, passed the appropriation, passed the monies. But now when it comes to the issue of now issuance, because remember, Peter, these letters were issued by respective county governments. These are the county governments that actually did the interview. They interviewed all of these officers, then issued them with the contracts. And therefore, it is the same county government that are supposed to be issuing them with the permanent and impenetrable letters. But you see now, it reached a point where the PS for medical services at one point requested for the reversal of the payroll back to the national government because of the inability of the county governments to effect this PNP establishment. Therefore, we are saying as healthcare workers, let the Council of Governors man up. They should actually not stop being the scapegoat here. You know, the cat and mouse games played by the Council of Governors surely is not fair for healthcare workers in this country. Let them understand, and they should actually know that health is a devolved function. They need to take up their mandate of staffing and take it. Actually, most of these counties are understaffed, Peter. To be honest, we're actually having a lot of strain to the healthcare workforce. Look at our healthcare facilities, look at the public health officers, the outbreak, look at the epidemics actually are emerging, and emerging diseases are actually coming because of understaffing. And I thought the Council of Governors will take this as an advantage and take over the UHC and give them PNP established so that they can be able to address the gaps that are there in the HRH. But to our dismay, they have actually turned it the other way around. The national government has actually come in place to give them our colleagues the PNP, but the Council of Governors are still insisting that they cannot be able to give our colleagues the PNP data that they actually deserve. And they are saying it's actually them who are on strike. They're actually the ones actually collapsing the health systems in this country. So tell them, man up, we need to have a robust system.
Is there evidence to support those claims?
Sorry?
Is there evidence to support those claims?
Yes, of course. Yeah. If, for example, we appropriated money, this money to that effect. I want to be sincere. This money to confirm permanent and impenetrable terms to UHC. Why is it that the Council of Governors is dilly-dallying to issue permanent and impenetrable letters? What is the problem? I mean, the money is there, the allocation has been done, so they should do their constitutional bit of ensuring that our colleagues receive PNP letters. They're actually the ones on strike, not the healthcare workers. It is the governors who are actually on strike, not us. So let them hasten their bit. Issue as letters as early as tomorrow, as early as even today. We'll be able to tell our colleagues to go back to work. But if they're not willing to be able to do their bit, it's actually going to be very much. And you've seen what's actually happening in Kericho and other counties. Kenyans are suffering from a healthcare crisis because of what's actually going on. So it is important. The Council of Governors should actually take up their mandate, issue PNP letters to our colleague, have a centralized way of negotiating with the unions, the recognition agreements and other things, so that we can be able to take care of what's actually supposed to be done.
Do you want to say something?
Yes,
before
I also want to add something.
Yeah.
As much as we're talking about these permanent pensionable letters, remember, there are colleagues who joined the service or they were contracted back then, probably they're in 40s or early 50s.
Yeah.
Right now, they're approaching retirement. What are they taking home? Nothing, after serving the government for all these years. There are those who feel like they've undergone depression, they've even lost colleagues, because they look at the back and forth, they're being tossed at the county, they're being tossed back to the national government. So as much as we're insisting that we need the permanent pensionable, let's have them, let them be effected as soon as possible, let them also get that gratuity, so that now moving forward, we discuss other matters, which are so many. And let every county be responsible, so that they stop looking at each other and, just passing blame to each other. Let every county government take responsibility, knowing it is the people that are being served once we get the letters and go back to work.
So is there any progress in negotiation that gives Kenyans hope, hopefully the strike will end soon?
Well, like we've had, Waziri gave a nod. He was like, the national government has done its part. We might say today there is a flicker of hope, but again you wake up tomorrow to very disheartening news. Some branches will say, why should we sign the CBA? What is there to sign? About the UHC team, today some counties they're okay with issuing the UHC letter with the permanent pensionable, but majority of them are still they're declining. And now when you ask yourself, which language are they using? The COG is adamant.
Yes.
We are the people that the buck stops with us. The national government says we have done our part. So the flicker of hope, again, today it's there, by evening it's gone. So we need that voice. Let the COG speak up. Let them declare. Today we are signing the letters, we are issuing them, and the SRC has already factored in. So we get the gratuity being factored in the budget, and these people go back to work. Yes, please.
All right. Let's touch on UHC before we carry on.
Yes.
The government has invested heavily in universal health coverage. Has the investment translated into better services on the ground?
Well, to translate, we go, when we talk about investment, we're talking about budget. Budget in this case. We're talking about, I hope you mean maybe the community health promoters, you're talking about the primary health care.
Precisely.
Because remember, in our previous budget, we had around close to 138.1 billion shillings allocated to health care. To us, it's a bit of improvement from previous budget. However, it still fall below what is actually expected of us. Out of that chunk of money, 13.1 billion went to primary health care. And it's primary at that community level that actually the chunk of work is done at the primary, at the community health level, at the household level. So we can be able to say authoritatively that there are some slow, this progress, but the progress actually is slow, because we are not seeing most of the county government embrace all what is supposed to be embraced, because we're talking about monies being allocated, but then the workforce itself, the HRH component, is actually not there, because you can allocate money, Peter, but when you don't have people who are supposed to be implementers of these policies, then you still have a problem at the end of the day, because at the end of the day, you'll build hospitals, you can build dispensaries, you can build medical supplies, but medical supplies and hospitals cannot be able to treat patients. We need healthcare providers to be there to be able to treat patients, to be able to.
So we have an issue with staffing.
We have a whole issue about the staffing component, which is actually we're actually very low, and the county government are not actually employing, and this is the reason why we're actually calling as healthcare workers. The debate about the Health Service Commission, and I think we are facing a problem, and this is the right time. And I feel, because we are in electioneering, we are actually approaching electioneering here, we're actually proposing to the government that as we vote for our leaders, we also need to have a Health Service Commission. As healthcare workers, we vote for it, because we feel, as a nation, counties have failed to manage healthcare services in this country. And therefore, it's important, just like education, just like security, just like anything, health is also very important to this country. We want it managed at the national level. Yes.
So what lessons have we learned from our universal health coverage program exposed about managing healthcare and the workforce?
What I would want to say is that UHC, it's based on paper.
Yes.
That it's being practically done. Remember, we have got Vision 2030, and all the components is that by 2030 you need to have accessible, free, affordable healthcare for all, not for a selected few. So what we are seeing currently is that today we achieve a step, tomorrow you go 2 steps behind. Because when you strike, what are we doing? We are undoing everything that we had achieved initially.
It's true.
So in terms of UHC, we'd want to say it's being broadcasted out there for everyone to see, but when you come on the ground, the story is totally different. And I can tell you for a fact, if you move to every other government facility, you'll be saddened by what you find on the ground. And I can say before devolution, probably things were better. You know, health was doing well. But again, devolution came, we saw good progress at the beginning, and then something happened along the way, and all these achievements were brought to a halt because there are a bit of politics that are being played here and there.
What are some of those politics?
No, there are politics that are being played here and there. When we talk about, you know, implementing their policies that we want to implement, we print newspaper, we put it all over the media. But again, when the implementers, who are the implementers? If you can segregate the healthcare force, whom else will implement it? Like my colleague Daktari has said, you cannot expect the beds, the infrastructure, the buildings to implement what the UHC entails. But if they cannot see a mere, you know, remuneration for that healthcare worker, so that they get also motivated, so that they continue also ensuring that we achieve what we want by 2030, then I can tell you for a fact, UHC is better seen on posters, on media, but on the ground, it's a totally different story. Yes, please.
Let's talk about some of the reforms that are needed, you know, to now deal with this situation so that we can avoid repeated healthcare workers' strikes. What are some of those reforms that you would like to see?
One thing the reforms I'll want to see majorly in health, let's depoliticize health in this country. Let's not politicize health. The problem we have had, know that this country does not suffer, it's not that we do not have the good policies. The policies are the Kenya Health Sector Policy 2014-2030 is there. We have the Digital Health Act. You know, all the framework that is supposed to operationalize UHC is actually there. Because look, both from the legal and institutional. But the problem we're actually having is that we're actually politicizing the whole issue. If you go to our counties, you find out that our governors, our good governors, are giving people positions who are actually not qualified to be able to manage healthcare services in this country. We are not employing, it's part of reforms. We are not employing because since 2010, since the onset of the new devolution, we have not employed healthcare workers. And when we're actually campaigning for this government, I'm a good student, we actually met with the president at the Catholic University when we were actually preparing a manifesto before the onset of and actually the president promised to employ 20,000 healthcare workers. We have not seen that promise coming to fruition. So we want to see adequate employment of public health officers, adequate employment of clinical officers, adequate employment of nutritionists, nurses, doctors. Look at the ratios. We're actually falling below the required ratios. People are actually, there's a lot of burnout, Bwana Peter. There's a lot of healthcare workers actually flying the country because of a lot of work. We're actually working to up to what more than what we actually expected to work. And therefore that was is actually affecting service delivery.
Does that also affect the quality of healthcare?
It does.
Definitely.
Yes.
Yeah, because one of the areas that it will affect is that a healthcare worker will go to school, come back with papers, but then the government, they're not resignated, they're not redesignated to appropriate job description. You'll not be promoted. You have to wait, you have to lobby, you have to use all means, and I'm telling you at the end of the day, nothing happens. So what are we telling this healthcare worker? Why did you go spend money? All your money is, you know, in school, training 4 years, 6 years. You come back and then you tell you, keep waiting. Keep waiting, where years are still passing by. You're providing a service that you're redesignated, you're not redesignated for that job description. So what does that tell you? Go to, for example, what we call, you want to pick a PI cover, professional indemnity. They're told, we need your redesignation. Where is it? So there are small things that really, really matter. And at the end of the day, it becomes a mall. And when we do that, what are we telling our people? You don't need to go back to school to study, because when you come back, nobody recognizes you. If every one of us took a step and said, I'm not going back to school, what will happen? What will happen to our service delivery? The people retired will go home. There'll be a big gap. Okay, and then there will be mismanagement. So at the end of the day, it's a vicious cycle, and then it will come to haunt each and every one of us, no matter the status you have in the country. So what we want to tell the government is that let us have systems run. Let them not run on one side, and all these other sides, they're all dormant, because time waits for no man, we say. Yes, thank you.
I'll give you a perfect example. The other day, we are struggling with Ebola. And was it today or yesterday? I've seen Uganda saying that it's now free.
Ebola free.
Ebola free.
It was yesterday.
Because it was actually yesterday. In this country, we are still grappling with the same issues to do with the emergencies and actually epidemic preparedness. And I'll give an example of public health, because PHOs are actually employed at the border points to be able to take care of issues to do with the screening of travelers, issues to do with the surveillance, for example, disease surveillance, for example. If there's an outbreak of cholera or whichever nature of disease, and any communicable disease, there's actually an issue of disease surveillance, and also issues to do with trying to ensure that we contain the outbreak. But you know, we cannot do that because we are actually very few. The healthcare workforce is actually very few. Even if you were to put up isolation centers, even quarantine centers in this country, they will not be of any value to us, because the people who are supposed to be working in those isolation centers or the quarantine centers are not there, and therefore it becomes a problem. Even to service delivery to a patient, the timely, you know, the waiting time a patient is supposed to be served. Actually, our facilities actually, I've seen patients who die at even casualty areas, not because they want, healthcare workers want to, but because they are actually overwhelmed. So what we are saying, the same spirit that the national government had by employing 56,000 teachers, because we are aware, we live in this country, the government employed 56,000 teachers. Police officers are being employed on annual basis. The same spirit, we want to see it in the healthcare. Yes. We want to see close to 100,000 healthcare workers being employed so that they can be able to address issues to do the epidemics, PHOs, nurses, clinical officers, and doctors, so that we can be able to at least be free, be able to be happy when you're actually talking about our healthcare system. But with the politics and with the push and pull of our two levels of government, actually what we are seeing is supremacy wars. Each government that seems not to understand what is the actual role in all this issue. And it is important, it's high time that now we need to understand if another government is not actually taking its role seriously, the counties, the health now should actually be reverted back to the national government, that can be able to see Kenyans get the required healthcare services that they need, because it's a right in the Constitution of Kenya 2010. Article 43 is actually a right. Curative, preventive services is a right to our Kenyans. And what we're actually asking is not a favor for the government to do us, because we pay taxes, we actually have gone to school, we need to make sure that we offer these services without any disruption.
So, Christine, is that to say that you're not satisfied with the government's response so far?
No, with the national government we are, but the counties, that is where the whole problem arises. Yes, because the national government, they've done their part. Yes. They've actually even recalled, like my colleague has said, they've recalled back the payroll, just to ensure that there's seamless payment of our UHC team. But what is happening at the counties, there's that push back and forth. The COG speaking one language, delivering the other. So I wish there was that goodwill from both types of, from both levels of government, so that we see, instead of this push and pull, let's have things streamlined and our people will go back to work. Yes, please.
Let's talk about the impact that this has on patients, because every day the strike continues, patients are now being turned away from public facilities and forced to seek expensive private care. How do you balance workers' rights with patients' right to health care?
We have to draw the nexus. But you see now, the problem we usually have as healthcare workers is that in as much as we want to treat, in as much as we want to prevent, in as much as we want to promote health, surely, or honestly speaking, an empty stomach cannot be able to work. That's for free. If, for example, I don't have fare to go to my place of work, Peter, even if you were to perform miracles, I can't reach to my place of work. And therefore, that means the patient is actually going to not to suffer, actually going to get the required service. So what we are saying, in as much as we want to balance, the government has to do its bit. Everybody must be able to balance. Let the government do its bit, let the healthcare worker or provider do its bit, let the patient get their service that he so actually needs, because that is his right within the Constitution of Kenya 2010. So if all of us, if all the players, if all the stakeholders in the space of healthcare system did their bit as expected by law, I can tell you free will not be able to experience what we're actually experiencing in terms of the paralysis you keep saying. And you know, we're also tired as healthcare workers. We cannot be going on strike year in, year out. We want also to reach at a level that we say now, we're also very happy with the healthcare system, the way it's actually being managed. But with the ongoing things, the way actually supposed, the politics and what have you, we are likely to stay here for a very long time. I'm worried to say so.
How much time are we talking?
Yeah, we are likely to stay.
Indefinitely. Indefinite for lack.
Yeah.
Okay, and maybe also to add on that, remember, the strike is usually the last resort.
Exactly.
We signed a return to work formula in January 28th.
Yes.
Matters that we agreed upon, the county governments had promised to come on board, sign the CBAs. What happened? 6 months down the line, it's a push and pull. What are we supposed to do in that scenario? We give them a strike notice of 14 days. Guys, just wake up, sign the CBAs, implement them, implement our scheme of services. We'll not go to the streets.
Okay.
What have they done? They've remained adamant that we will play, we will. You know, they keep on saying we will or we shall. Now, up to date, we are still there. No commitments, no goodwill. Now, before we went on strike, I remember there was that, you know, they give these last minute, midnight, they start calling, let's come on the table, let's negotiate. How are they? 6 months? I mean, 24 hours?
Yeah.
And just yesterday, was it yesterday or the day before yesterday, we are seeing county governments, some are responding. You know, we call that a knee-jerk reaction.
Yes.
They're saying, come on board, let's sign. But again, tumemaliza kusign. What happens? What happens after that? There is no goodwill to implement. So what does that tell you? We'll still be here on the streets. And when you see people on the streets, we are just coming to the doorsteps of these COG to remind them, guys, wake up. We are serving you coffee at your doorstep. Just wake up, do what is required of you. If they do not want, we'll sit back at home. We'll come on the street, keep rallying, and until the day they feel the need, and they'll feel the pressure from the people they seem to govern.
Okay.
Yes.
So, Brown, are you saying these issues could have been resolved before they escalated?
Of course,
to the national strike?
If there was a goodwill, you know, there are procedures before you go for a strike in law. One, you give a demand notice for a specific period of time. Two, you give a strike notice. Then 3, there's now the real notice. All those days, the government has an opportunity to engage the healthcare workers. There's a provision in law that even a conciliator through the Minister of Labour can be appointed to conciliate between the warring factions. But now we see, when you give a strike notice, the government is not talking to you. They're actually sitting down to wait whether to, it's like a wait and see game. It's now actually where the problem actually comes from. But as healthcare workers, we've always said, even in our strike notice, we remain available for amicable resolution. We remain available because, I mean, at the end of the day, we represent these workers who are supposed to be speaking for them. So if the government fails to invite us on a table to negotiate, I'll call it now, what is saying, it's termed a knee-jerk reaction. They call a few counties and say, you know, we can talk. You know, that's a knee-jerk reaction. It is important that they call us in time. Even right now, if they want to call us even right now, we have no problem. Because we'll still go to the Minister of Health, we'll still go to the Health House, Council of Governors, sit down with those officials and discuss and have these issues sorted. Because remember, today, the nurses joined the strike. You never know what will happen tomorrow. And let me tell you, Peter, you know, unless you have a sick patient, me, I lost my father because in a casualty. This year in March, I lost my father in a general hospital in a casualty. It pains me to the core. But now, you see, the healthcare workers who are supposed to be attending to those patients are actually not there. You get it? So it actually pains a lot when we have a government that's supposed to be listening and paying attention to the issues surrounding the entire healthcare sector is not giving it time. That's the problem actually comes in. So it's important that the governments come in, invite healthcare workers on a table, negotiate these things, we actually have it done and dusted. And we're really actually willing to go back to work and work immediately.
So sorry for your loss.
No, it's okay.
Has the trust between the government and healthcare workers been broken?
The trust?
Yes. Now that we are talking about this.
You know, it's like a marriage. When you lie to me,
yes.
When you have an agreement, the way the carrier said, we sit down this table and then agree, for example, we are going to pay us by 5th of every month. For example, we're going to honor this CBA, we're going to honor this RA. Then you don't honor it, then automatically the trust goes away because we no longer trust each other. So let them trust. Let them, if they want to build trust with healthcare workers, let them implement what we actually agreed on the table.
And maybe also to add on that, we're having this national strike. And again, there are issues that needs to be resolved at the national level. But I know the crisis is coming back home at the different counties. Because one, the deductions, the statutory deductions are not being remitted. There's the issue of payments for salaries that are delayed you find you on the second or the third month, they don't pay of salaries. So I wish the COG could sit down with the team. Let them agree. We are solving the issues at both at the national and at the county level so that we also do not have the same games being played back and forth. Because let me tell you, once the healthcare system is crippled, returning it back to its norm, it will be a tall order. If nurses on strike, they have similar issues that need addressed. So if we keep on piling, it will reach a point, it will be beyond repair. And who will suffer? It is us out there, it is our people who will suffer, and we might not be able to salvage, even that would have been salvaged before. Yes.
Okay. Brown, so if the current situation persists, what long-term public health risks should Kenyans be concerned about?
We should be concerned because we pay taxes and we are not receiving the health care needs as required by the Constitution of Kenya, 2010, Article 43. Kenyans need to be worried, particularly with the Council of God, the way they're handling health issues in this country. You know, sometimes it's good to speak them out. They say speak truth to power. We have to tell them because we are not happy, I think, the providers, the way they're treating Kenyans in the way they're handling healthcare issues as a whole. We need to ensure that we have, for example, we have timely drugs at our stores. We have a timely response to epidemics or infections. We have timely employment of workers, healthcare workers on time. And then also the ambulance services are actually also timely. Remember, there's a lot of strain. In the moment we keep playing around, push and pull, we also invite a lot of strain to our healthcare facilities. So it's actually supposed to be worried, but one solution we're actually providing to government, the national government, is that let us revert back the healthcare component to the national government. This issue of cat and mouse between the governors and the national government should not actually be there. A serious government must be able to take care of the health of its citizens. And therefore we're asking humbly that in the next election, in this election, that let us vote that health goes back to the national government so that we have it run properly. The same way teachers, we have a teacher service commission. We see how it's being run professionally. We have police. I've never seen a problem with the police. I mean, security is actually doing well at the national government. But then now the health component at the counties is actually crippling because of those influence from the county or bosses. So we should actually agree that yes, the health sector has actually failed. Let's take it back to the national government. Let's ensure that we have everything timely done, because we can be able to see a sigh of hope with the way the national government is actually doing things. It's good to be frank sometimes. We are happy with the way the CS Dual has handled the whole issue about the UHC. He came in, I remember he came in when it was at the height of it all. And he has actually tried to bring some level of sanity from the Minister of Health perspective in terms of the way he has handled the universal health coverage issue. The President also has done this, has tried and done the same. But the problem is that our county bosses, we're actually requesting them, if they're not actually in a position to handle healthcare, let them allow healthcare go back to the national government so that it can be done properly.
Have you had any meaningful engagement with the county bosses?
Yeah, you know, they all say that it's individual counties. So you engage with this one, they give you that hope. They tell you we'll sign, we'll implement. But it's one thing saying and it's another one acting. And that is where now there happens to be not bad blood per se, but for lack of a better word, there exists now the bad blood, because promises not kept are not promises. So that is what is giving these back and forth. And like the Dr. said, if health was reverted back to the national government, we'll be speaking from one voice. It will be the healthcare workers versus the government, versus the ministry. But again, if you have 47 different governments, what happens from there? Different languages, different voices, different promises. At the end of the day, we are not achieving anything that was meant to be achieved. Yes.
Back to the impact this may have on patients. Have emergency and critical services been maintained, or are lives being already put at risk?
Well, that definitely will happen. Why? If the public health department decides we've had enough, we are going out here, what will happen with disease surveillance? We will not be able to pick Ebola once it's at the borders. We'll not be able to pick any communicable disease that is at the borders. Back to our health facilities. If there are no services that are ongoing, we'll have cases of increased non-communicable diseases, the hypertension, the diabetes, name it all. And then what will happen? Those who are affected, if they're not able to afford services at a private facility, we'll see mortality rates going up. We'll see our women not being able to deliver, you know, or deliver in an unsafe environment. So what is this telling us? That we have a crisis, and the crisis must be sorted as soon as possible, failure to which it will affect us all. Yes.
Yes.
Yes, crisis needs to be sorted. What guarantees are you calling for before you call off the strike?
The only guarantee we can give to Kenyans that we can go back to work when we have the PNP letters for the universal health coverage colleagues, when we have a centralized way of negotiating RS, and then when we see county government implementing the CBS for our colleague unions like the KUKO. But without that, I can tell you free, we remain reluctant, because we also have families to keep, Peter. We have relatives to take care of. We have bills to pay. We have everything. We also need to give ourselves upkeep. And again, we go into school to actually be able to benefit from what we're supposed to gain, what we gain from school. So we cannot sit down there pretty well and assume that things are okay when they're actually not very okay. But I want to say that the national government, honestly speaking, I have not seen anywhere in law that talks about the Council of Governors. I've perused the Constitution of Kenya 2010. I've not seen a faction, or rather an entity called Council of Governors. It's a creation, in my view, it's a creation of county bosses. So we cannot allow, the national government must not be able to allow an amorphous body like a COG to be able to control them. Because honestly speaking, COG is not a creation of the Constitution of Kenya 2010. We know the bodies that actually constitute the Constitution of Kenya 2010. And I have not seen anywhere we're talking about the Council of Governors being a constitutional body in the Constitution of Kenya 2010. Therefore, let the national government take decisive measures to ensure that we safeguard Kenyans from these all issues. Because God forbid, if there could be issues, for example, we have people who have suffering from cancer and other things, they're actually suffering. They don't have medicine. Remember, at the beginning of this year, we also faced the U.S. actually withdrawing their funding from the healthcare sector. I mean, HIV has been an issue, malaria has been an issue, TB has been an issue all along. PEPFAR funds actually when they were withdrawn. So whatever small things, the small monies we have, we need to utilize them for the benefit of Kenyans and also for the benefit of the Kenyan patients. Yes.
And for clinical officers, the bare minimum, the PNP, let the letters be issued, let the gratuity reflect on the pay slips, let it reflect in their bank accounts, let the scheme of service be implemented at the 47 counties, including at the national government. And last but not least, let's see our people be promoted. Let us see them redesignated, so that now we are sure that we are not coming back to the streets to remind the COG of their role, failure to which we continue dancing to their tune up until the day they wake up and say, let's resolve this thing. Okay.
Christine, this is to you. Beyond this, the strike,
yes, please.
What does it reveal about the state of Kenya's public healthcare system?
Yeah, thank you for the question.
Very good question.
It saddens me. The question you've asked, to look at the milestones we had achieved pre-devolution and right now.
It's true.
Money is being pumped to the 47 counties, but what is happening? The priorities are no longer being observed. The priorities they think is, because I want to come back and another term, I'll put up infrastructure and tell my people I built hospitals. But what is contained in those hospitals? You open those curtains and you don't want to come back there. Look at the state of the wards, state of the theaters, you know, the personnel working those facilities. You want to tell me now that you're doing well? We are absolutely doing wrong. And look at the number of strikes that have happened ever since devolution came in, vis-a-vis what happened before a devolution. That is in 2010. You can really tell that there's been a big difference. And I can tell you, if as people are able to voice up what we're going through, the patient back there, down there, can really relate to what we're saying. And they'll tell, indeed, health was better at the national government. And if we keep on piling these we keep on piling issues, one up to the other, it will be too late to salvage the healthcare. And private sector is not the way to go. The way to go is safeguard our public healthcare system, ensure that the systems are in place and things are being implemented to the latter. Failure to which we keep going back and forth. Yes, thank you.
Brown?
Yeah, thank you. Peter, I want to say that it's a sudden state. It's a sad state, both at our national referral facilities and also at our county governments, where we have seen health being managed. But however, the government has an opportunity to reimagine healthcare in this country. Let's ensure that we hold responsible and accountable all people who actually been assigned with the responsibility of managing our healthcare system in this country. Otherwise, with the continued sad state, I can assure you we'll actually going to be seeing a lot of emerging and re-emerging infections coming back. We have seen Ebola, we have seen COVID-19, Marburg actually coming back, chikungunya. We'll see them coming back because of the inaction and the inability of our county governments and national to be able to manage healthcare in this country. Therefore, we don't want people to fall sick, and actually, I believe that is what we believe in as a nation, as public health officials. We will decongest hospitals. We don't want people to fall sick, but with the continued inaction by our national government, or rather our county government, to take up serious measures, they're actually putting us in the same hole that we're actually trying to talk about. So let us be proactive enough. Let's not be reactive. We have a sad state where we become reactive instead of being proactive. We don't plan. We don't plan, Peter. This country, we don't plan. We wait for a crisis to react. For example, there's a crisis of an epidemic, now we react. We form committees to address issues when we are supposed to actually be planning prior to those crises or prior to those epidemics before they actually be able to happen. The only best way to plan is to be able to revamp our healthcare, to be able to employ enough PHOs, to be able to employ enough CEOs, to be able to employ enough healthcare workers to be able to take care of any need that may be able to arise out of any crisis or any epidemic. Yes.
Now, for patient watching tonight, and they ask, why should I support this strike when I'm the one who's suffering? What would you say to them?
Well, today they're suffering. Tomorrow their lives will be better. And I can tell you, nothing good comes easily. And until we voice out as healthcare workers, the patients will never go on strike. You never find them holding placards.
Yes.
But it is for us, we are their voices. And when you speak out, you're speaking to the same government that the people voted in. So if that patient may not support us fully because they know, I've been told to just move my patient, you guys are not attending to us. But in the long run, they'll appreciate why we are on strike. And I can tell you it's just a matter of time. And like Dr. has said, I want also to retaliate. We are not on strike. It is the government that is on strike. And precisely the county government, the 47 county governments. Yes, please, we're just reminding them. We're just beating drums to wake them up. Yes.
The other they wake up, the better. We are actually pleading with the chair of the Council of Governors. Please tell our governors to be able to man up. We have no problem with any county boss, but in the event they want to misappropriate health, we as healthcare workers, we are not willing to walk into that direction. We are willing to sit down and negotiate and be able to go back to work, but let's ensure that we give our colleagues the permanent imperishable letters as quickly as possible. Give them gratuity, give them and promote them, and then we can have a central way of negotiating our issues, then we'll be able to go back to work.
Have you received any support from the public, or are Kenyans increasingly frustrated?
No, of course there's
with strikes that keeps coming back.
Sorry for the interjection.
No worries.
Of course, there's that small number that keeps saying, Dr. you guys, please remain on strike if your issues are not being addressed. You know, it doesn't make sense if a patient walks in and they find you're lethargic. You know, you're not attending to them, and they're wondering, Dr. are you not paid? Are you not on salary? And now you wonder, if only you knew whatever happens behind the scene.
Yes.
Because poor pay.
Do you want to mention some of the unique challenges that you face?
Of course, I will, and I may not speak it as individual, but I can tell you generally with the team that is behind me. One of the issues I can tell you is that you go to your clinic or to your clinical room, and you find the basic equipment that you need are missing. So you're forced to improvise. Whereas the government tabulates every year, we've given this amount of money to the healthcare sector. Where's this money going to? And then another patient walks in and they ask you, Daktari, why are you not doing this to me? And now you want to tell them, but again you hold your breath because you want to attend to them and move to the next person.
Yes.
Again, you find a facility, patients are just piling, but the services they're coming for, I mean, is not commensurate to what the government proposed to speak is providing. So when there's this double speak, now the patient wants to put you between the government and themselves. And it is you they will roast because they say, who is the government? It's an invisible body. And that's why as healthcare workers, we've decided to say, the government is not an invisible body. We have the 47 county governments. We know who sits on those seats. Please speak out for us, or else us guys will go to the street, rally them to speak for you people. Yeah, so basically, the patients are supporting us. Majority, of course, are not. But the few that are supporting us, they're telling us, please remain on the streets. We also want your health, we want your services, but again, not at the expense of us finding you in a very bad state as a healthcare provider. Yes, please.
I'll also say it is in the best interest of the patient to have drugs in the facilities. It is in the best interest of the patient to have a doctor that is actually has a morale boosted. It's the best interest of the patient to be able to ensure that when you walk in a facility, you actually coming out with drugs and everything else. And therefore, this strike is not even a healthcare strike, it's actually a Kenyan strike, because if the healthcare is not working, then I think all of us, we are not actually not working. Remember, we also Kenyans, we also want those healthcare services. We also have relatives who also need those healthcare services. So, all the agitation we are doing here and also in the entire country, it is actually in the best interest of our healthcare service systems to be able to work so that we can be able to fulfill the Constitution of Kenya 2010 Article 43. So Kenyans, we are with them and we feel for them. We feel for them. We want to go back to work. Kenyans, we want to go back to work. But ask your governors, ask your county bosses to allow us to work, because we can also not work for 6 years on a contract, surely. It's not fair. According to the Labour Relations Act and the Other Employment Act, it's actually also not very fair, because our rights are actually being trampled on, and we can't allow do that. Yeah.
Yes, please.
Yeah.
Yes, final remarks as we wrap up.
Maybe to begin with, my final remarks is to thank. I'll thank the CS at Duale for being actually authoritative and ensuring that we actually transform the terms of our UHC colleague to permanent independence. But I also want to thank the President for actually also supporting the same cause and ensuring that we actually have the universal health coverage. Number two, I also want to ask our members that, remember, we are still on strike. The National Executive Council has not called off the strike, and therefore we will only go back to work the time we'll be able to see all our UHC colleagues with the permanent pension letters in our hands, and then their service gratuity paid, and also those who need to be promoted, being promoted, and also ensure that we actually have a centralized way of negotiating our recognition agreement. But for the Council of Governors, please, we are willing to sit down to talk, and we will actually want to talk so that we can be able to finalize on this issue.
Yes.
Thank you.
Now, as my parting shots, I want to urge the Council of Governors, stop having that hard stance. Let's come to the table. Let's sign the CBAs collectively, let the 47 governments, let's implement what we've signed, and let's ensure that there's continuity of services. And to the clinical officers out there, we are still on track. We are not on strike. We're just reminding our county governors that wake up, sign whatever is required, give us all what we require, and we will go back to work. So our strike as clinical officers is still on up until when the General Secretary will call it off. Thank you.
All right. Thank you so much for your time, Brown. Christine, thank you so much.
Yeah.
And we do hope tonight's discussion has shed light on the challenges facing Kenya's healthcare system. Now, to a developing story that we are following, several parts of the country have been plunged into darkness tonight following a widespread power outage that affected major towns including Nairobi, Mombasa, Eldoret, Nakuru, and other areas. The disruption, which began shortly after 8:20 p.m., has sparked concern among residents as reports of power loss emerged from different regions almost simultaneously. Kenya Power has confirmed that it is experiencing a widespread outage affecting customers in Nairobi, the Coast region, Mount Kenya, and parts of the Central Rift, while noting that some areas in the North Rift and Western regions remained connected. The cause of the outage has not been immediately established. Wow, thank you very much.
Thank you
for that very, very insightful conversation. It was a pleasure having you. I'm hoping we can have this discussion once again. And hopefully, the next time you guys come, things will be a lot better.
Yeah, we are hopeful too.
And we'll also be inviting you one day, we call it off, also to celebrate.
Please
to celebrate.
Yes, we'll be happy to celebrate with you.
And confirm.
Asante sana.
Asante sana. As usual, thank you so much for making us a part of your evening. My name is Peter Kamau. Our interpreter is Rhoda Nyamai. From all of us here, have yourself a pleasant evening and take care. Good night.